I'm sorry, Chairman Faison, you're recognized.
Thank you, Mr. Chairman. And this is to the senator. I just wanted to, what's it like to be in a place that we actually study the bills as opposed to what they do?
That was not fair at all. Had I known he'd said that, Senator, I wouldn't have let him talk. Chairman Sexton, you're recognized.
Representative Faison is a good friend.
Thank you, Mr. Chairman. For the department again, I think the question is, since there are none technically, how many would this affect statewide if this goes into effect?
Chairman Sexton, the clinics that, again, air quotes, clinics that we're aware of, there are about 5 that we are aware of. 2 in Senator Yeager's district. 1 that we have talked to, Dr. Reach, I think that would qualify as one under this the formula in front of you in this amendment, and then maybe 2 in Johnson City and 1 in the Franklin area.
Chairman Sexton.
We really don't know though. Beyond that,
right.
Beyond those,
and so we had this discussion before, but just for the record, since there's approximately 5. The reasoning of not grandfathering those in and then doing the CON from this point forward, like is usually done. I think there was other bills that look at that. The reason behind that is.
Can I call up Dr. Carter, our chief pharmacist? He's also our state opioid treatment authority.
Dr. Carter, state your name for the record.
Yes, I'm Jason Carter. I'm the chief pharmacist for Tennessee Department of Mental Health and Social Services, and I'm also the state opioid treatment authority. Currently, I regulate what you would refer to as methadone clinics. There are 12 of those across the state. Those methadone clinics do go through the certificate of need process to make sure that they are needed in the community. And as part of that, they really need to make sure that they're going to contribute to the order development in the community. That then allows us to license them. It allows me as a state opioid treatment authority to go in and regulate them. Right now we get calls about, what are you going to do about this Suboxone clinic that opened up in my area? Well, actually, I can't do anything about that. We have no authority to go in. So if it were somebody that was regulated by us, then we would have the ability to go in and look and make sure that they're providing all the things that a patient that wants to be in recovery needs to be in recovery, to make sure that they're getting appropriate monitoring of the medications that they're getting, that they're doing urine drug screens to make sure that they're not diverting their medication, that they're taking what they're supposed to and not taking other medications. We also do callbacks. We know that buprenorphine is an abused product, that we've seen the prescriptions almost triple in Tennessee over a 4-year period, and that we have seen an increase in the amount of Suboxone that's dispensed, and that it is diverted, that we see criminal activity associated with it. In our opioid treatment programs, we have callbacks where patients are called back to make sure that they're not diverting that medication so that it doesn't end up in the community.
Thank you, Dr. Carter. Chairman Sexton.
Thank you. 2 questions. I'm assuming the methadone clinics weren't always in the certificate of need. At some point it was added into the certificate of need maybe. At that point when it was in, did we do that before there were methadone clinics already in Tennessee, or did we put in the process like we're doing here after the fact with those types of clinics?
And I apologize, that was actually before my time. I cannot speak to that. I do not know. I know for the past several years that there's been a CON requirement around the methadone.
Okay. And then the next question is I understand going the certificate of need, and that helps develop on how many you can have in any location based on
Correct.
need. My question is, if for some reason those were grandfathered in, those 5, they would still, if they didn't have to go through the certificate of need, you would still be able to regulate them, correct?
That is correct. As long as we were able to see them as a non-residential opioid-based treatment program facility, then that would give us the authority to be able to license them and regulate them, which allows us to then go into that program to look at the records, to make sure that these patients are getting adequate counseling, adequate drug screens, and everything that they need to push the patient into recovery.
Right. Okay. Well, I appreciate that. So basically what I'm hearing is that there is the possibility to where they would be under regulations, those existing, if something like that happened.
So I would assume if they meet the same definition of our rules as an opioid treatment program facility, then we would have the authority. I would actually defer to Kurt Hipple in case I don't want to speak out of turn on that.
Thank you.
Kurt, would you like to answer that question?
Chairman Sexton, Chairman Williams, I believe we would have to tweak the rules a little bit, but we have that rulemaking authority. And, of course, we would do that through a rulemaking hearing so that all parties, all stakeholders would have a chance to voice their comments.
Representative Hill.
Thank you, Mr. Chairman. Mr. Hipple, thank you for being here today. Got a couple questions for you. Why don't you all just through rulemaking set up the regulations that you feel is lacking and would be necessary? Why do you feel it is necessary to go through the CON process?
Well, I think it's kind of what Chairman Sexton was talking about earlier. Right now, because of the definition that we have for opioid treatment center for addiction, it does not contemplate the private practice portion of the buprenorphine prescribing. So in order for us to license, we'd have to fix that definition first, and then we could license.
So why don't we work on the definition instead of going, y'all are wanting to go all in with this whole CON thing, and when we already had one bill that dealt with that of a similar nature, and you knew how, I don't want to speak for the committee, but we had a lot of questions on it. Now we're in this other posture where we don't even have, by your own admission, we don't even have a working definition of what a Suboxone clinic is. I think we at the very least need to get that before we jump all the way over to CON. And in addition to that, I am very concerned, and I want to, after we have, I know we've got a couple more speakers, Mr. Chairman, so at some point I want to talk about the concern that I have that, and I know this isn't your intent with the legislation or the sponsor's intent, but as I look through it and talk through it and work through it on my own, I am very concerned that we're going to inadvertently be handing people over to methadone clinics and patients over to methadone clinics as runover and as additional, for instance, in rural areas where they may have these clinics once we can get it defined. If they're no longer there, and I'm talking about the good actors, no longer allowed to provide the care, these people are going to need treatment somewhere, and the only other place to go is methadone clinics. And that's unacceptable. That is beyond unacceptable. I've had methadone clinics keep trying to come into my district, and thankfully the community has been successful in getting rid of them on a pretty continual basis. But I don't know how long we can continue that. I think we need to define, I agree with you, we need to define what Suboxone clinics are, but then we need to go through the rulemaking process and work on that. We do not need to go to the extreme of the CON and inadvertently, which I know is not the intent, but inadvertently put people in the rural communities over into the hands of the methadone clinics. That's an awful idea, and I know that's not what you want to do, but I see that as a potential outcome of this. Thank you, Mr. Chairman.
Representative Hill, to respond to that, the reason that the definition has to be changed the way it has to be, and the reason it affects CON is because that definition is in the CON HSDA statute.
Representative Hill.
Yes, I understand that for the purposes of this proposed legislation. However, we can bring legislation, you can bring legislation, we can work on legislation that specifically defines what a Suboxone clinic is that does not require a CON, and then you can promulgate rules and regulations to deal with that, just like you do lots of other medical entities across the state. So we don't have to do a CON. You would prefer that, obviously, or you wouldn't be standing there, but we don't need a CON. We can define Suboxone clinic, and then you all can promulgate rules to regulate them as you see fit. But we don't have to define them for purposes of CON. That's just what you would prefer, correct?
In the framework of how the law is written now, that's how we would need to proceed. But as you're talking about, if there was a new way of going forth, then yes, I guess we could do
Okay,
that.
thank you.
Thank you, Representative Hill. Any other questions for these? Seeing none, going back into session for a point of discussion between the members. I've been speaking with the legal staff for the members over here. Section 3 of this bill is the section of the bill in which it deals with the grandfather. I think, as for me, I'm more concerned about the state operating without a definition of these clinics and the opportunity for them to be in a CON. If I made what I'm proposing to do is to make it, because this is the last committee, because I don't want us to operate another year without it. If I were to make a motion to strike Section 3, based upon legal staff, Section 3 from this amendment, it would alleviate the concerns of the grandfathering of those people who are existing and operating in the state. It would allow this bill to move to full committee, which would allow us to further communicate about it. Before I move forward with the motion, I just wanted to talk to the members about that. Representative Hill, you're recognized.
Thank you, Mr. Chairman. I appreciate the fact that you're wanting to work on this. I think all of us, even on the testimony from the department, that this does need work. I mean, I have information, and one of the speakers is going to bring forth information as well, that this state of Tennessee is being watched very closely on this bill, and if we pass this bill, there's going to be a class action lawsuit filed alleging that we are violating the Americans with Disability Act. We need, and I agree, we need to study this, we need time on this, and I'm not making a motion in deference to the chairman because he has the floor, obviously, but I think at some point we need to seriously discuss as this subcommittee and consider putting this in summer study so that we can work all of these issues out so that we can address the problems that the sponsor has in his district. But with a potential impending lawsuit and a whole bunch of other issues we haven't even talked about yet, I would very much be inclined and much more comfortable to just work on this over the summer. But that's not a motion. I'm just responding to your question, Mr. Chairman.
Any other discussion for the sponsor?
I just want to reiterate one thing. And what we're trying to do, every doctor, every general practitioner that you go to right now can subscribe up to 100 patients on Suboxone. So that will not affect anybody out in these rural areas. Every doctor can do that. We've also put a provision in there. If it's a multi-practice agency where you've got 50 doctors, say, they still get to prescribe up to 100 each. We're not affecting that at all. What we're trying to do is prevent the circumventing of the law by a group of doctors going out and open up a storefront, and it's not a clinic, it's a storefront, and you've got a PA in there that's subscribing Suboxone, and they can put them up anywhere, and they don't have to have a public hearing, don't have to have a certificate of need. And that's what we're dealing with. I mean, it will not, as far as getting treatment for people, it will not reduce that at all. But I'm at the will of the committee as far as the grandfathering clause, and I will agree to do that, please.
Thank you, Representative. Any other questions? After consultation with the attorney, I'm going to make a motion to strike Section 3 from this bill. It's an entirety. From the amendment, we have a motion and a second on the bill. This would be Amendment 1-1. Are there any discussions on the verbal amendment? Seeing none, all those in favor of the verbal amendment say aye. All those opposed? Roll call vote on the verbal amendment.
Representative Clemens? Doss? Faison? Favors? Hill of Washington? Kumar? Matheny? Sexton of Cumberland? Terry? Chairman Williams? 5 ayes, 1 no, 3 pass.
The verbal amendment we're back on the amendment as amended, which includes striking Section 3 from the amendment. All those, any question on the amendment as verbally amended? See, the original amendment makes the bill. Yes. Representative Hill.
Before we vote on this, since it does make the bill, I move that we go into recess. I have a gentleman that wanted to give testimony on this bill.
Without objection, we're out of session.
Thank you. Thank you, Mr. Chairman.
Please state your name for the record, sir, and the name of your company.
Mr. Chairman, committee, my name is Dr. Tom Reach. I'm the president of Watauga Recovery Center in Johnson City, Tennessee. I am board certified in family practice, emergency medicine through the AAPS, and board certified in addiction medicine. I'm also the president-elect of the Tennessee Society of Addiction Medicine. I would strongly encourage the committee to turn down this particular bill. The bottom line is that this is going to put the good guys out of business. This is going to help the bad guys. People who are running effective alcohol and drug treatment centers, providing 12-step recovery meetings, providing counselors and care, will not be able to afford to get a certificate of need. A certificate of need is incredibly expensive, cumbersome, and burdensome to the practice of medicine. And the question is, what does the certificate of need do? What problem is it that we are trying to solve? Do we have a bad doctor in La Follette? Do we have a bad doctor in Harriman? Maybe. Does this bill solve that problem? No. This throws the baby out with the bathwater. Specifically, they say this will stop Suboxone clinics from popping up on every corner. The reality is, at our clinic, we have 30 physicians seeing 2,500 patients in 5 different clinics. We provide complete biopsychosocial care for our patients. If we were to take every individual doctor and allow them to see their 100 patients, they would open up a different clinic on every corner. There would be not any less Suboxone on the street. There would be less quality of care because we would not be able to provide the adequate 12-step meetings, the counseling, according to the American Board of Addiction Medicine, the American Society of Addiction Medicine standards. They say that this will limit the amount of Suboxone and Subutex on the street. I don't disagree that there's a problem with drug addiction in Tennessee. Tennessee is ground zero for the drug addiction problem. The question is Suboxone and Subutex part of the problem or part of the solution? Yes, there are 3 times more prescriptions for Suboxone and Subutex in Tennessee in the last 3 years. Thank God. Enough physicians are now able to adequately prescribe this medicine to treat the disease of drug addiction. Our vision is for a society that views drug addiction as the disease it truly is and treats addicts with the dignity and respect that they deserve. Anything that limits the ability of physicians to care for drug addiction in the state of Tennessee is going to cause problems. This is like, oh, we got a problem with Suboxone clinics, chop off the head of the hydra, 3 more problems will pop up. Where are these patients going to go? They're going to go back on the street. They're going to go back to heroin. They're going to go to methadone. They're going to go to pain clinics. What are the bad guys going to do? They're going to open up in Kentucky. They're going to open up in North Carolina. They're going to open up in Alabama. It hurts the bad guys. It helps the good guys. I strongly encourage you to vote this down.
Thank you, Doctor. Any other testimony in regards to this bill while we're out of session? Chairman Sexton has a question for the department.
Appreciate your testimony. The department, if you can answer this, obviously you're doing a certificate of need based off the methadone clinics having a certificate of need. Is that right?
Yes, sir.
So can you tell us why it's important, you think, to mirror the methadone certificate of need, what you've seen with those types of clinics and what that maybe has done to that type of clinics compared to what you're doing here? I'm sure there's reasons on what you're looking at for.
Yes, Chairman. I'll be happy to address that. The 150 number, in addition to the 50% or more of the caseload, the 150 number came from a rational basis test. We wanted to figure out what does that threshold need to be. And so we looked at our smallest methadone clinic in the state, and they have a daily census that averages between 150 and 175. So we picked that number there because methadone and Suboxone are very similar drugs. They're not the same. They're very similar drugs. One's a Schedule 2, one's a Schedule 3. They both have abuse potential, but both, the way they're used is where the similarity lies. Methadone and Suboxone are both substitution-based medications. You substitute an illegal opioid for one that is legal to use. And that's where we have drawn those parallels between a methadone clinic and Suboxone.
And then the other thing, if we did not have the CON for the methadone clinics, what would be happening right now in the department's mind?
If we did not have a CON for the methadone clinics, CON allows us to orderly develop health care, to make sure that there's a medical need for that health care in the area, to make sure it's economically feasible so that if it's operating one day and then runs out of cash the next day, that it doesn't go away and that people who are patients of that facility don't have anywhere else to go. So I think those are the reasons that we have a CON. We have a CON for OTPs.
And then the last thing is, who can prescribe Suboxone in the state of Tennessee? Can physician assistants do that or just physicians?
No, sir. Only physicians with a DEAX number. They have to go through some additional training, about 8 hours. They have to register with the DEA. So
we're not going to have clinics opening up running by PAs in the state of Tennessee?
No, sir.
Okay, thank you.
Only physicians.
Dr. Kumar, you're recognized.
Thank you, Mr. Chairman. Kindly clarify that by bringing these clinics under the CON process, would it enhance your ability to monitor them and collect data, or would it be the same?
It would, Representative Kumar, it would enhance our ability to monitor. Just the couple of things that Dr. Carter said would be key. Requiring counseling so that the individual who is seeking out this treatment has the best possible chance of succeeding in that treatment and living a life in recovery. Second, instituting some drug diversion control programs that would say, okay, I'm going to prescribe you 100 tablets at the beginning of the month, so we know that they took those 100 tablets and didn't just take 80 and then diverted them or sold them or traded them for some other medication. That doesn't happen a lot, but it does happen. We want to make sure that we safeguard the community by having those drug diversion programs.
Okay.
Lastly, it would allow us to, if we did get a complaint from the community, would allow us to go in and be able to respond to that complaint and investigate.
Okay, so you'll be able to monitor their performance better.
In short, yes, sir.
Okay. Also, by allowing clinics or office-based facilities that see less than 150 patients, is there 150 total census? Right.
It's 150 150 or more who are on buprenorphine. It would not be their entire practice.
Right.
They had a mix of family practice and addiction practice.
So allowing these clinics not to require a CON if their census for this particular treatment is less than 150, are we going to drive a lot of these clinics into splitting and having additional facilities? It's the Starbucks phenomena, so to speak.
That is a possibility, but again, this bill its main purpose is to get that good definition on the books, an operable definition on the books, so that we can start to institute these safeguards. And the point is not to try to drive this very important addiction treatment option out of the state.
Are there, I guess that may be a question for the sponsor, if there are any safeguards that a clinic, instead of getting a CON, splits into 3 clinics and assigns 149 patients to each. We have to anticipate things like that. Well, thank you. Thank you, Mr. Chairman.
Representative Hill.
What is the department's position or comment on the impending class action lawsuit against Tennessee if we pass this legislation? The federal government has weighed in and said that they are weighing, I'm going to be clear, they are weighing their options as they observe what we do, how we act on this legislation. What is your all's comment or position on that?
I know you hear this a lot on the news, but we don't comment on any potential or pending legislation. But in my knowledge, potential and pending are 2 different words with 2 different definitions. Potential means that it could happen. Pending means that it is happening. It's just in process. And I'm not aware of any lawsuit that's been filed as a result of this bill.
You are correct. It is potential. And if we pass this bill, it will be pending. You are correct about that. Second question, on the fiscal note, and of course the Fiscal Review Committee submits their stuff to you guys, and then you submit information for the fiscal note. The fiscal note currently says not significant. How much does it cost to apply for a CON?
That information, we do not run the CON application process. That's HSDA, the Health Services Developmental Agency.
To be fair, it's about $15,000.
My understanding is that the minimum fee for a CON for a methadone clinic starts at $3,000.
Representative Hill.
The minimum fee.
Minimum, yes. It's my understanding, and I apologize for being a little leading there, but it's my understanding that it will run about $10,000 to $15,000. And also, because to your own admittance or the earlier testimony, unless I misunderstood you, you don't know specifically how many of these are in the state. So there has the potential to at least be, as we like to call in these fiscal notes, additional or other fiscal impact. I have a really hard time believing the not significant on the fiscal note, knowing that there will be additional paperwork, additional personnel, additional individuals needed for this, and that is just a side comment. My final question.
Thank you for the side comment.
Thank you.
Representative.
I have a question. It's a very serious question, Mr. Chairman. I have a facility in my district that offers everything from the treatment with the medication to counseling, 12-step programs, spiritual counseling, accountability, the whole gamut of care. If we pass this bill, they shut down. Where are my people supposed to go?
To their doctor?
Or to a methadone clinic that's right across the way in North Carolina. That's an awful, awful alternative.
Thank you, Representative Hill. I had a couple questions for you, sir. How many members are in Tennessee are in the Tennessee Society of Addiction Medicine?
That is an excellent question that I cannot adequately answer for you today, sir.
Do you know any one other person other than you?
Oh, certainly.
Okay.
John Sandridge is the president, Alexander Zotos, Richard Soper.
Would you guess there to be 100 or 1,000 or 10,000?
I would say we're probably up to 200 to 300 members in Tennessee.
Okay. Do you currently do drug testing on every person that you see in your clinic?
Absolutely. We
do. Do you currently count pills as it relates to every person in your clinic?
Absolutely.
Okay, so when a member comes in, they do that. In striking Section 3 of the bill, which allows you to be grandfathered in, which allows the state to have a definition of what Suboxone clinic is, why, based upon my communication with you, why would you not be in favor of this?
Mr. Chairman, I agree with the intent of this bill. I think that it's a noble reason. I think there are people out there doing it wrong. I think we need to study it further. We need to define the problem further and then come up with more comprehensive solutions that will encompass both sides of the aisle and will match with our national directive to increase access to medication-assisted therapy, not restrict it.
What do you think is the cost for you to do a certificate of need?
I tried to get a certificate of need.
No, I'm talking about the fee that Representative Hill said earlier.
It was well over $15,000 by the time we were done.
How much would it cost you to order a class action lawsuit in case this bill goes through? Is that more or less than $15,000?
I have no idea, sir. I would never consider doing that.
Thank you. Any other questions? Seeing none, we're back in session. Any further questions for the representative on the bill?
Can I have one other comment? And I'm sorry, Representative Doss, did you have something?
I'm just checking on the posture of where we are. One moment, please. Okay, we're on the amendment as amended.
Okay.
Representative, you're recognized.
Okay. I think Representative Doss had a question, please.
Chairman Doss.
We've been around and around, Mr. Representative, and first, I think you need to be applauded for your efforts. I think we all know in this room that we have many addiction problems in this state. We have drug abuse problems in this state, and I just applaud you for your efforts, and I would hope that each member would take this very serious. There's upwards of 1,100 people dying by overdose deaths every year, and we can put this off year after year. Meanwhile, we're not living up to what the people expect us to do.
Right. Thank you. I just have one further comment, and then I'll close if you don't care. But
yes, sir.
What's happening right now, they can do this in any storefront. There's no regulation on it. They can put it next to a church, next to a daycare. There's no regulation at all out there right now on these offices, they're actually a satellite office. They're not a clinic. They're a satellite offices where you have a group of doctors that open one up, and they might serve 200 or 300 patients out there. There's no public hearing. There's no certificate of need, and they can put them anywhere they want to. And so that's the kind of problem we're doing, and they can put them in your district and in your neighborhood. So let me just close real quick. This is, if you don't care, if you'll allow me to quote Congressman Tim Murphy from Pennsylvania. He's a psychologist by training, and he said buprenorphine can more safely maintain a person's dependence by reducing the need for illegal opioid use, such as heroin, thereby the risk for overdose. But make no mistake, buprenorphine is a highly potent opiate, which according to SAMHSA is 20 to 50 more times powerful than morphine. According to the Drug Enforcement Administration, when police conduct a prescription drug bust, the third most frequently seized drug by law enforcement is buprenorphine. More than methadone, more than morphine, more than codeine, and unlike clinics that administer methadone, there are no requirements for buprenorphine clinics to offer or even discuss the non-addictive treatment alternatives with patients. No requirement to develop treatment plans, no requirement to protect the public against buprenorphine being diverted for illegal use. That's what we're dealing with right now, Mr. Chairman.
Thank you, Representative. The posture of the committee is we have verbal amendment on the representative's amendment. Any other questions on the amendment? Members, we are voting on the amendment. All those in favor of amendment number 2. Oh, I'm sorry. As amendment 1 as amended, all those in favor of that amendment say aye. All those opposed? The ayes have it. The amendment goes on the bill. We are back on the bill as amended. Any further questions for Representative Hill? You're recognized.
Thank you. And to the sponsor, I agree with you. We don't need the storefront clinics. Those are absolutely inappropriate. We do not need those. I'm more than willing to work with you on that. I agree with the department that we need a specific definition and they need rulemaking authority to set the rules and regs. I 100% agree with that as well. But the testimony of the department and your testimony have proven that we need additional work on this legislation. This is not meant to be hostile, but it is meant to be firm in the respect that we have addiction treatment centers in this state that are doing it the right way. They are doing the drug testing. They are doing the pill counting. They are doing it the right way. And by requiring them to spend tens of thousands of dollars one time and then on an annual basis as well is something that needs to be, I just don't think is the right way to do it. And I've already expressed my concerns about the methadone clinics as well. But in light that this needs additional work, Mr. Chairman, I would like to make a motion that we move this bill to summer study with the true intent to try to address some of these concerns that obviously need additional work.
We have a motion and second to move this bill to summer study. Parliamentary procedure says it takes a simple majority to send this bill to summer study. All those in favor of sending House Bill 929 to summer study, say aye. All those opposed? No. House Bill 929 goes to summer study.
Thank you, Mr. Chairman, members of the committee.